So we'll just give it a few minutes while everybody joins.
You're muted, Lwazi.
Thank you very much. My apologies. A very good morning to everybody who's joined us, and we are also live streaming on all of the government websites and pages. To the Honourable Acting Minister, Ms. Mammoloko Kubayi-Ngubane, the Deputy Minister, the Director General, senior managers, broadcasters and other media houses, thank you so much for joining us this early morning at 7:34. Let's get on with it. We do have a program for you whereby we will be discussing the latest on COVID-19 and the epidemiology, and then we'll go straight into vaccinations because we know that that's what everybody really wants to know. We will start with the Honourable Acting Minister, and then we will then be joined by a panel of experts from the department as well as from associated entities to talk a little bit further about the programs. We're joined by Dr. Nicholas Crisp, who is no stranger to the media environment. We'll talk a little bit more about the vaccination plans for frontliners. We'll also speak to Dr. Barry Kisnasamy, who's going to talk a little bit about workplace vaccinations, of which they've done some pilot studies. And then we know that you've had some problems with the Evds, so Melanie Wilmerans is going to join us, and we're going to talk a little bit about that, and we'll talk a little bit about troubleshooting. And then we'd all love to know what happened with the Sisonke trial, and so far what the head investigators have found. So Professor Glenda Gray will join us for a bit, and she'll just talk a little bit about that and what they're seeing for now. And then finally, we'll be joined by Professor Helen Rees from SAPRA, who's also a member of the Ministerial Advisory Committee on Vaccines, and she's going to talk a bit about the other vaccines that people are very curious about. We'll then have a question and answer session, and to members of the media who are in my group, I will open up the group, but you can also pose your questions onto the chat, and then we'll close out with the Deputy Minister. So without much further ado, thank you very much, Honourable Minister. I see you are ready. Thank you for opening for us, please. The floor is yours.
Thank you very much, Dr. Lwazi Manzini. Good morning, panelists. Good morning, colleagues from the MEC. Good morning, Deputy Minister, DG, and colleagues. Good morning, South Africans. I think we're taking this opportunity to brief you, bring you up to date with information that relates to how we're managing the pandemic, but also our vaccine rollout. There's been quite a number of issues that have been raised. And I think many of you, having listened to the president this week, would have noticed that the president announced that we are now in third wave. because we have breached the 30% of the previous wave. And that's how it has been worked out by the epidemiologist and how the team has been able to say, this is what we need to do. Now, one of the things that we would want to communicate today, as you saw the statistics, I think the first thing as I start looking at the statistics, the past couple of days, you'd have seen that the numbers have been almost above 10,000. Yesterday, we were at 11,767 new cases detected. And this is at a 22.5% positivity rate. Now, when we look at this, you would understand that this means that the transmission outstripping our ability to detect, and also in terms of the rapid spread in our communities, it's very important for us to note that where we are, and especially my message is to those in Gauteng, and then also, but we are monitoring the provinces. Gauteng is becoming one of the areas that we are very, very concerned about. For the past few days, we've been working since Saturday with Gauteng to try and ensure that we can be able to bring down the numbers, but they have not gone down. If you look at the rate of infection currently, you would see that that actually shows that we have passed the numbers of the first and the second wave in Gauteng. And that's very much worrying for us. So, and what is worrying more, as I said, even in the portfolio committee yesterday, is the activities that we are seeing around Gauteng, firstly, in terms of people still participating in protests, still participating in illegal gatherings, because we have really restricted the gatherings from the announcement by the president when he moved us to alert level 3. Now, when you see what we have done in terms of alert level 3, you note that we've restricted in terms of gatherings to 50 indoors and 100 outdoors. And we are hoping that as we work together with our law enforcement agencies, I did see Gauteng as well, when we were talking with the premier, we saw a lot of people going out in terms of the law enforcement to assist us, but it has to take many people who are actually responding to a message like we've seen previously. Now, the message that I'm sending to South Africans, especially those that, for example, are not adhering, is that you are risking not your life, but you are risking the lives of your loved ones. You are risking those that you stay with, your colleagues and your friends, because when you go to a protest march, for example, it's chanting, it's running, the observation of the protocols. Literally, you see some people running without the mask as well. Some people almost destroying properties, burning tires. In the process, you are sharing these things and you're holding these things in your hands from one hand to the other. And that's putting a risk to other people. So we are appealing to Gauteng residents who are currently every day, and so on the 16th, yesterday as well, are not dropping in Gauteng. We are seeing community spread in terms of the virus, and we really want to appeal that can we also respond, save the lives of many South Africans in your province, and also assist us, because the health practitioners are starting to be under pressure. What we have done from our side is that we've started to work together with the province. Yesterday, after the conversation with the president and the Minister of Defense and military veterans, we have requested additional capacity to assist Gauteng in terms of military help that has moved into the province to assist us swiftly. And I want to appreciate the minister, together with the defense military help, who have responded swiftly when we called them yesterday afternoon to say, please come and help us in Gauteng. What this will do will be able to release the capacity of the beds that have been held because there were no human capital. So they will assist us in terms of moving into the hospitals, into the areas where we need healthcare practitioners to assist us in managing, because in terms of the beds, you have to have the human capital that is linked together with the beds that we are making available for managing the pandemic. The second area that will intervene and assist us is around mass testing and mass screening in community, and also the contact tracing. They will be able to assist us in terms of that, moving into Gauteng. So we are zooming into Gauteng, And today we are finalizing because the province has also asked us to help them in terms of ensuring that we can bring capacity in terms of the Department of Health. I've had a discussion with Minister Mtunu, who is assisting us that we should be able to conclude that today. So yesterday, we were able to agree with the Minister of Defense and Military Veterans for the deployment of the military help into Gauteng, which will start from today, as per our discussion, so that we can be able to help the process of ensuring that we ease the burden of the health workers in the province where they are seriously under pressure. And this, you'd understand, maybe one of the things that I need to reflect on is that other pressures are brought by, you'd remember that the Charlotte Maxeke Hospital, which has had, in terms of bed capacity, it's got 1,000 that currently is not available for us to utilize because it was evacuated. There's been discussion between ourselves as national department and the province together with the municipality to ensure that we can comply and bring back the hospital back to functionality. The process is underway. We are hoping that in the coming weeks, the engineers will assist in terms of finalizing the work and also giving the certification for occupation of the hospital so that we can be able to see that coming back into life. But that will not deter in terms of the work that we have done, redirecting the bed capacity in Gauteng, redirecting the, ensuring that, for example, if you would have seen the circular that went out in terms of having to say to the health practitioners and to the hospitals to say non-critical and non-urgent surgeries would have to be postponed so that we can pay attention to what needs to be done now. Another area that we want to talk about is to be able to give in terms of the recovery rate that has steadily at 95%. And I think in terms of the MEC, the colleagues will be able to go into this. And also the exciting news yesterday at 10:31, we were able to pass the 2 million mark in terms of vaccination. This at 10:31, the person that passed the 10 million mark, 2 million mark that helped us at 10:31 was at Simunya Clinic in Western area. So we were counting because we are monitoring live in terms of the activities of the vaccine rollout. And this is good news because when you look at what we are dealing with in terms of ensuring that we can build immunity, the higher the number we are able to vaccinate of our population, the better we'll be able to manage the pandemic. And we should not also think that when we're saying that you are going to vaccinate, you are going to, people should not lower their guard and stop protecting themselves by wearing their mask and social distancing and also sanitizing. This is to ensure that by the time we reach immunity in terms of the community, in terms of the entire South Africa, at least we have managed to protect the lives of those that are most vulnerable. Currently, that's where we are focused. Dr. Crisp will go into details about our vaccine rollout. Other good news, we have been able to talk about the President announced the 300,000 vaccine that would arrive. I can confirm that that happened yesterday on the 17th of June. At 17:45, we received the consignment that arrived in the country, and Dr. Crisp will go into detail because that has been identified as well to assist us for the teachers in the country together with other frontline in terms of police. He will go into detail in terms of the preparation that is being done around that area. I think the other issue that is important, you'd remember that when we talked about the phase 2 of the vaccine, we primarily proposed or put in terms of the plans that would have firstly the senior citizens or what we would call 60 plus population. And in this, because it was understood that in the 60 plus population, majority of them would have comorbidities and therefore becomes are vulnerable more. And that's why it was critical for us to start with them. We have wanted to vaccinate in terms of our population of that category. We have more than about around 5.5 million. Currently, we are not really doing well. I must be upfront about it in terms of registration and vaccination. And we are looking at mechanisms to be able to intervene so that we can fast track. One has gone through the research reports that has been produced by HSRC together with UJ, and the other one was released this year as well, just after March, by UJ, where they were studying communities to understand their response to vaccine, and also they were doing work that they wanted to understand whether communities are buying into our vaccine program, whether there's concerns from communities. And one of the things that has come sharply out of the reports is the issue around cost to our sites. Our intention is to make sure that the sites, the vaccine sites, are closer to the community. So the vaccine must go to the people, not people going to the vaccine. So an example of this research, they've done a deep dive into, the researcher went to, for example, into whether they've been able to register those who are 60 plus, what are their issues, and how do they recommend for us to be able to respond. This is important because when we respond in what they've raised, this is based on the research, as we have said as government, that it will be evidence-based. Now you go and look into that. One of the issues is that a person who is in Protea South have to go to Lens Clinic to be able to vaccinate. For you to go to Lens Clinic, it's 2 taxis and 44 rands at a cost. This is one of the things that as we work this week, going to next week to IMC, we'll work around the clock to respond to that in terms of increasing of the sites that we have to pay attention to, making sure that our response respond to making that the vaccine comes to the people, not that the people have to, because that's what we understand. If you understand the logic even around the senior citizens, it means when I have to have about 50 rands for transport, meaning that the senior citizen will have to wait for the payday when they receive their grant to be able to go to vaccinate. In registration, I think we've been able to respond very well because we've gone into the communities in terms of door-to-door to register them, and the researcher is able to identify and has been able to meet some of the people who've gone into the door-to-door to register. We go to pay points in terms of SASSA to register them. We go to the malls to register them. And one of the things that in terms of vaccination, we have to respond is to be able to find mechanisms where we do the similar way of going to the people in terms of vaccinating. But the colleagues who are here from MEC, both Professor Reed and Professor Schupp will be able to assist us in terms of going into the details around what we need to do. I think the other thing in terms of what we are doing, colleagues will be able to take us in terms of the piloted size. We have previously talked, even you have had the economic cluster requesting that economic activities have to come back in terms of life, being able to work properly and assist us in terms of saving lives and livelihoods. One of the pilots that we had to do during this time was to be able to assist and do a pilot. And Dr. Barry Kisnasamy will go into the details in terms of our occupational health as our occupational health expert in terms of the work-based vaccination system, testing site which has been piloted, what is it that we can do in terms of rolling out? Because one of the things that we are trying to do is to have a multifaceted approach in terms of the vaccine, making sure that everybody can be able to vaccinate properly. And we do not have like a one system that does not respond to all the sectors, but also can be constrained and might not be able to respond to what we want to do. So if you look at that, you'd find that we've gone into, for example, the mining sector to look at how we can utilize that sector to be able to vaccinate those who work in that sector. And the lessons that are learned will be shared in that area to be able to assist. I know many of people who've been saying that we are frontline staff in terms of the economic sector, and therefore for us to be able to operate, would be able to, we need to have the frontline staff to be able to be vaccinated. As the Minister of Tourism, I would have previously talked about that in terms of those who are actually interacting with our travelers, because they would have said that they are uncomfortable to interact with maybe tour operators or tour guides who are not vaccinated. So that area would be able to be covered by Dr. Barry Kisnasamy to be able to say these are the lessons in terms of our pilot site and give us in detail how we plan to go and go forward. We'll also go into the discussion around other vaccines. I know many people have been asking questions about what is it that we are doing in terms of the vaccine rollout, or even bringing more other vaccine around. Many questions will be asked about Sputnik, about Sinovac, and all other vaccines that are available in the global platforms. How are we utilizing them? Because sometimes people think that we've just decided on 2 vaccines that are not really assisting us to go forward in terms of broader work that we have to do. So the colleagues who are going to give us in terms of details, in terms of the vaccine, how the MEC does the work in analyzing the vaccine acquisition in the country in terms of the recommendations, which vaccines would be suitable, because you'd remember, South Africans, that one of the things that we have to make sure is that the vaccine efficacy has to be in such a manner that it can help us to protect our country and protect citizens. So there's been previously, as Minister Mkhize previously would have briefed us, that there is a level of efficacy that we have agreed on that we need to be able to meet in terms of the vaccines that we get, but the process thereof, because there is an application process with the regulator. So if you are a pharmaceutical that has a vaccine, in terms of operating in the country, the registration process, but also compliance with WHO requirements in terms of providing data that has been used in terms of the scientific analysis of the efficacy of the vaccine and it being able to respond. But also for us, it has to be able to respond and help us, and it has to be effective against B.1.351 variant that is in the country. So it's very important in that, as well as we do the work that we are doing. So that is important for us to be able to get in terms of the details that we are working on. But again, as I conclude, I just want to say, for the colleagues who are not in Gauteng, in terms of the regulations that have been issued, we have issued the regulations because people have said, some of the people have raised the concerns to say, no, we can't have the same restrictions that are applying in Gauteng to the areas where there isn't a huge spread. We are saying when we look at the numbers, we are seeing an upward trend across the provinces. So that's why the regulation had to be applied across. That's why the entire country has moved to level 3. And all of us have to be cautious, because if we do not contain currently, what we are seeing coming up is likely to affect us all across the country. So it's important for us to be able to deal with this right now in detail, making sure that we can contain and utilizing the lessons from previously in terms of our how we dealt with wave 1 and wave 2, or second wave, if we call it that way. So it's very important for us to be able to understand as South Africans the importance of us adhering to the message that has been sent. We know that you are tired in terms of being in your houses, but right now it's not the time to lower your guard, because you could be compromising your loved ones, you could be compromising your colleagues, and we are urging those that if there is no need for you to leave your house, please stay in the house. Go out to do what is absolutely necessary, because we have to weather the storm right now of the 3rd wave, and we can only do that with your help, with your support. Thank you very much.
Thank you very much, Minister, and let us all heed the call to adhere to the non-pharmaceutical interventions. Thank you, Minister, for that update. I'd like to invite Dr. Nicholas Crisp now to join us. Hi, Dr. Crisp, I see you're ready. Dr. Crisp, please, the floor is yours.
Morning. Good morning, Minister, Deputy Minister, DG, colleagues, and those participating in the seminar. So I'm briefly going to outline what we are doing about the total rollout, starting with, of course, what everyone knows. We began with the Sisonke trial and managed to vaccinate 479,000 people during that initial period. Since the start of the main national rollout, which was on the 17th of May, we have now, as the Minister informed us, crossed the 2,000 vaccination mark. And what has constrained us has been the lack of availability of vaccines. All the provinces and the private sector providers have been champing at the bit to open additional sites. And as we know, if we want to get closer to the people, we need more sites and we need more vaccine. The situation at the moment is that that process will continue to roll out. but we are fortunately now received the 300,000 doses that we have been looking for bridging the J&J conundrum that we had when the FDA locked up vaccines. And we will immediately start rolling out 2 programs and followed by others. The first one is the education sector. Altogether in that sector, there are 582,000 people. That's the public and the private basic education sector, including all those employed on Purcell, the SGBs, and the private educators. Many of these people have already been vaccinated, some because they're over 60 and some because they work as psychologists and others who are registered as healthcare workers. But the majority of people obviously still need to be vaccinated. The program is designed to, with a major thrust that should be over within 10 days, 10 working days, and all the provincial health departments and provincial education departments are going to focus on vaccinating educators in this period. The 300,000 doses will obviously not be enough to complete all of that sector, but fortunately the next consignment of vaccine is due next week. It's also from a similar source in the United States, and it is also on a short expiry date, which is why we are accelerating this program over such a short space of time. The Department of Basic Education is organizing that schools, the staff of the schools go to the designated vaccination sites for this program and will be arranging transport to enable them to get to those specific sites. It's a very specific program. It's not the normal program for the general community. And we're just asking teachers and the other staff in the education sector when they're called to the vaccination site to remember to take their ID documents and their medical aid if they are a medical aid member. The second major program that is now in an advanced stage of planning and will roll out pretty much immediately upon completion of the teachers is the security cluster, starting with the police services, which planning is in an advanced stage. The South African Police Service is working together with Polmed and GEMS. About 145,000 people are covered through the Police Act and a further 36,000 through the Public Service Act. Those are the civilians working in the police services. And all of those people are targeted. There's slightly different programs for the two of them because of the uniformed or the Police Act people being dealt with in a particular way. So there will be sites at police stations. They are working together with pharmacies who have licenses and are designated points for the delivery of the vaccines. And there's a service provider working with the South African Police Services for vaccinating members. And there's a service provider working with the Department of Public Service and Administration and GEMS for the other workers. Finally, there's also a program that is rolling at the moment for the South African Defence Force and for correctional services. Each one of them has got a different set of needs. The Defence Force are clearly the uniform members in terms of the Defence Act. And fortunately, the Defence Force has its own military health services, so they will be vaccinating their own members, whereas in the corrections, the inmates will be vaccinated through the through the correction services, but the staff will be vaccinated through the same program that is run by the Department of Public Service and Administration with GEMS. So I think maybe I should stop at that point just to say that there are a lot of parallel processes. In terms of the volume of vaccines, we will have, besides the Pfizer vaccine that we already have in the country, we will have an additional 2 million doses in the short term. And by now, the Johnson & Johnson deliveries will recommence so that we can continue with the program. Thank you very much.
Thank you very much, Dr. Nicholas Crisp. Good news that we are prioritizing our frontline workers. Dr. Barry Kisnasamy, we will give the floor to you as you're ready to share your screen. Thank you very much. The floor is yours.
Morning, Minister, Deputy Minister, DG, and colleagues, and to the participants in the webinar. So I'm going to quickly look at the issues on the workplace delivery and basically just stop my video for bandwidth purposes and Chair, I take it that the slides are showing.
Thank you. Yes, we can see the slides and it's in slideshow mode. Thank you very much.
Thank you. So, as Minister has pointed out, we are looking at the issues around the workplace delivery mechanism. And just to remind colleagues that on the webinar that we essentially phase one was on healthcare workers as a special category of workers. And then phase two started with the general population and then what we call the rest of the workforce in terms of occupational services. The unique feature of workplaces is while the general population is operating at 60 years and above in terms of starting with older persons, the workplace population is an age band of 40 years and above. Just in terms of some of the data on the workplaces, we have 15 million workers in the formal economy and 7 million in the informal economy, like the waste recyclers, street traders, the taxi sector. For the purpose of this presentation and the workplace interventions, we have segmented the taxi sector, which does a considerable amount of work in terms of transportation and has both risk to themselves as the taxi sector. These are the taxi drivers, the marshals at a taxi point, the conductors, etc., as well as possible transmission risk to the commuters that go in the taxis. So that's the only grouping we've carved out, but I'll talk a bit more on the formal economy, which we split into the public sector. And Dr. Crisp has spelled out that there are some unique features that are covering the public sector and elements within it, like the uniform services. And then the private sector, we split into large and small and medium enterprises because the unique features affecting these. Many of the large sectors have got strong occupational services, particularly mining, large parts of the auto and manufacturing sectors, but the small medium enterprises really have virtually no services in terms of workplace delivery of services. And Dr. Crisp has covered the special program covering health workers, basic education, security cluster, and the public service. So there have been many questions asked about sector prioritization, because we can't start on day one with a certain sector as we use the health workers. So we use a 2x2 matrix to look at contribution of gross domestic product and social impact, as well as risk of disease and severity, risk of death and severity of disease. So that was the 2x2 table. And we came up with some segmentation of which sectors to start first in a vaccine constrained environment. Similarly, colleagues in the trade union movement did some work, and the top right-hand side highlights some of the sectors. This is risk of transmission of infection in terms of what I call frontline workers in many instances. And you can see education is up there, police and correction services, retail sector, underground mining, etc. So just to remind colleagues, we're starting with the age-based sequencing in the workplace, starting with 60 years and above and move to 40 years and above, which is still in phase two. And the numbers in terms of the formal sector, we have about 416,000 workers above 60 years of age, and overall between 40 and 60, 4.8 million workers. So that's what we are concentrating on within the occupational health and service work stream. We've made some breakthroughs. There is the issue about individual registration on the EVDS, but in terms of workplace sites, there'll be bulk uploading of the workers onto the EVDS, of course, after being consented either by the HR Human Resources Department or the health professionals that might be at the workplace. But scheduling of vaccinations will be internal to the workplace site, going by the age band. So bulk uploading is 18 years and above, but scheduling for the vaccinations will follow the age bands. We also have a reimbursement model covering workers on medical aid. There's been a lot of queries about the medical aid funds, but this is a prescribed minimum benefit, and there will be recovery of funds for the vaccinations, the vaccines, and the vaccination administration from the medical aids, and workers not on medical aid will be covered by the National Department of Health. The Department of Employment and Labor has also set up a compensation fund for uninsured workers, and we're currently having discussions with them about how to access that funds. And colleagues might know that the Department of Employment and Labor has gazetted a direction last week on vaccinations in the workplace. So site selection is dependent on vaccine supply, vaccine type, Johnson & Johnson and Pfizer. For now, we are using Pfizer, but for certain workplaces, Johnson & Johnson will come through, especially the basic education sector, as Dr. Crisp has pointed out. And there are certain infrastructure requirements like the cold chain and social distancing and inputs. And essentially, the team that's been working has looked at number of workers by vaccinators, giving us high throughput sites not everything going to one sector in terms of the delivery mechanism, also not companies in only one province, so geographic location, and then lastly, site readiness to provide vaccination services. So the chair has mentioned the pilots with the minister. So we started one mining sector on the 24th of May in Northwest, and they vaccinated about 2,000 workers today, starting with age bands 60 and above. One manufacturing in Gauteng started on the 5th of June, and they have done about 700 to date, starting slowly but ramping up. One state-owned enterprise will start next week in Mpumalanga, and I think you'll see that we are trying to actually do some distribution by sector as well as province. One informal, the taxi sector, starting next week in Gauteng, and experimenting with the public service in terms of the Office of the Premier and the Department of Health in the Western Cape, notwithstanding the special program for the public service, but there were some unique circumstances that will pull this together. So one of the issues we've learned in terms of the two sites that have started rolling out is there is a fair amount of vaccine hesitancy amongst workers. So we're working quite hard to find out the reasons for the vaccine hesitancy and inputs on that, notwithstanding substantive work being done on what are called closed sites, because we have a captive population. Workers come to work every day, and we can deliver services, and we can actually counsel with them because we've got health personnel that can actually deal one-on-one, similar to other places as well, but particularly in workplaces. In terms of the next month, we're planning 145 sites in terms of the rollout. You can see the bulk are in mining because they've actually had quite substantive occupational health sites. We've then tried to look at some of the other sectors as well. And this is also provincially, geographically distributed, notwithstanding the sector prioritization process. So in summary, Chair, we are working with Business for South Africa and NEDLAC. So all the discussions we've had, the site selections, the information provided has gone through these structures as very important governance structures. We have finalized the model for site selection by sector, geographic area, numbers of workers, and site readiness. And we currently are working through 145 workplace sites to continue to move forward in terms of delivery of vaccinations through workplaces. Thanks, Chair, and over.
Thank you so much, Dr. Kistusami. Thank you. You can take down your presentation so that we can allow Ms. Wormerans to come through. After conducting some social listening exercises, we asked Ms. Wormerans to come through and just talk to the public about troubleshooting EVDS issues. We're just going to, thanks, Dr. Kistusami. Thanks, Melanie, then the floor is yours. I see you ready. Thank you.
Good morning, Minister, Deputy Minister, the Director General, colleagues, and the webinar participants. I think the electronic vaccination data system is on everybody's minds these days. So I thought it well just to give a brief overview of the electronic vaccination data system, demonstrating that it's actually bigger than just the registration and allocating individuals to a vaccination site. So the electronic vaccination data system of the South African government has been designed and developed to actually support the full matrix of events of the vaccination program. So that said, there's many components to the electronic vaccination data system. And these components include the first one, which most of the public and yourself are most probably interacting with at this stage, is the registration one, where individuals that opt in are registering themselves. And I'll just talk a little bit more about the registration just now. And then there's also a component where we are linking individuals with a vaccination site. And I will also just give a brief overview of that. But then there's also a component where we are ensuring that every vaccination site is actually complying with the legislative requirements to be able to administer a vaccine and have got the required permits, and that we know where each one of these sites are and also what the capacity in each one of these sites are in terms of administering the vaccines. And then very important, there's another component of the EVDS, which is the on-site EVDS, where there's an electronic record being kept or captured of individuals that gets vaccinated. And therefore, we can have a record of who got vaccinated, which vaccine they've received, what batch number, when the vaccine gets expired, is it a first dose, is it a second dose, who actually administered the vaccine, and that's part of, form part of the Evds. All of this information, we then in an aggregated way are doing the data analytics, and that allows us then to be able to provide on a daily basis data to the public and yourselves in terms of the number of people that's been vaccinated. But we also use this information for management decision making to look at where there are areas where there is a huge number of people that's registered, but there's not enough vaccination sites, so that we can target new vaccination sites aligned to where the needs are for the vaccine. So if we just zoom into the registration now, just to say that in the beginning, you will recall on the 16th of April, 24th of January, then the 16th of April, we had the registration for the vaccination was mainly through the web portal, or was actually only through the web portal, through the website vaccine.enroll.health.gov.za. In addition, we have added the option that you can actually also register through the WhatsApp, and you can also register through USSD if you've got an analog phone. And all of this is at no cost to the individual. All of this has been zero rated. And then we also have options where we can assist individuals that doesn't have access to the technology. One of them is phoning the toll-free number. And the toll-free number is 0800-002-999, where there is a call center agents that will assist the person to register. And then we also have at each vaccination site the option where people can also be assisted to register. And these are some of the additional measures that we have put in place. Listening to some of the information that we are getting from the ground, we're also now working on translating the registration into 4 main languages so that we can make it more accessible to our people in terms of enabling them to register. So just to say that once a person has been registered, we've got your record. So it's part of a database, and it's all into one big database. So once you've been registered and you received your SMS, and to confirm your registration, we basically are putting you in a queue and to assign you to a facility. Now, just to explain how the scheduling work, we have a team of people that every night, they start at midnight, and they run through the scheduling system. And while we still are opening up sites on a daily basis, the system are being rerun to look at if there is a site closer where you can be assigned, or monitoring how long the queue is of a person. So how it works, everybody that has been registered has been put in what we call a virtual queue. So they've been allocated to a vaccination site. Now, because of the fact that there's on a continuous basis new sites that are opening, we need to, on a daily basis, run this to see if there is that a date or a site that's closer or within the same suburb that has opened. And therefore, if there's a long virtual queue and you need to wait a long time, then people can be allocated to the new site that has been opening. And therefore, we're sending out the messages only 3 days before it's your time and day for your vaccination. And this allows us to continuously bring up new sites, working on the virtual queues, so that we can ensure that people can get their vaccine as quickly as possible. Also, in terms of people have to travel long distances, as Minister has mentioned, more and more sites will come online, and then more and more we can schedule people closer to, in terms of the indication of the suburb of where they are staying. So first of all, we look at the vaccination site and the capacity of that vaccination site in a specific suburb. If we see that that queue is very long, then we look at, is there possibly another suburb that's close by, that's got a shorter queue? And can we then allocate individuals to that specific one? And that sometimes leads to a case where people have to travel some distances, but we are continuously looking at how do we improve it, because it's exceptionally important that we focus on access to the vaccine. And the system shouldn't prevent people of receiving a vaccine, and therefore it's a continuous process of improvement. The one key thing that I just would like to ask is that we all work on informing people that they should focus on when they register, or when you register somebody or assisting somebody to register, that you ensure that you capture the ID number correctly. ID number is a very, very important identifier that we are using throughout the system. And we really want to plead with everybody that you make sure that your ID number is correctly captured. The other key one that's important, because we use that to communicate, and that is the cell phone number. So the cell phone number allows us then to inform that you have registered, inform where you should go for your vaccination, but also after vaccination, receiving a message to indicate that you have been vaccinated, also give you a specific vaccination code through an SMS, and it also then 3 days post the vaccination would provide you with additional information around the vaccine and what you can expect after vaccination. So those are just the key issues that we are looking at. The last point that I want to make is just to say thank you for all the feedback that we are receiving. It is important, and just to say that all the feedback that we are receiving, we are looking at it, and we are looking at how we can improve the system so that we can respond to the needs of the people. Thank you very much.
Thank you very much, Ms. Wolmarans, for clarifying some of those issues and for really crystallizing the EVDS for us again. I'd like to now invite Professor Glenda Gray, I did see her earlier, to talk to us about the Sisonke study. Professor Gray, surely one of the most seminal studies done in the history of medicine. Please give us an update.
Thank you very much, and good morning, Honourable Minister, Deputy Minister, DDG, and colleagues and the public. I want to report back on the almost 480,000 healthcare workers that we vaccinated. So what we are seeing from studies coming from all over the world is we're seeing good durable immune responses from the single jab. We see good T-cell immunity, and the kind of side effects we see are similar to other parts of the world and similar to other vaccines. And so there's no real difference that we're seeing. These vaccines, whether it's the J&J or the Pfizer, will reduce your risk of severe disease. And they may not protect you from infection, but they do protect you or reduce your risk from severe disease. And so we are following up all healthcare workers that have had breakthrough infections, and we're busy adjudicating them to make sure we can understand whether they're mild, moderate, or severe. At this moment in time, as we clean up the data, we are seeing a handful of severe infections, but most of them have been mild. Most of the breakthrough infections have been mild, and only a handful have been severe. Every breakthrough infection that we see, we do a genotype on to see which variant has caused the breakthrough infection. And most of the breakthrough infections have been due to our beta variant. And so it's very important for us to continue to evaluate that. As you know, at a global level, people are exploring boosting of the initial or primary vaccination series. And we think that the optimal time to boost a vaccination series would probably be around 6 months with the Ad26. So we're going to be exploring with other vaccines. And the first one we'll explore is an Ad5 vaccine boost, and this will happen towards the end of the year, where we'll explore boosting the single jab J&J. So that'll be an ongoing work that we'll be doing with the regulatory authority and ethics committees in South Africa. At this moment in time, we're also doing a lot of sub-studies with this single jab, J&J, looking at HIV-infected healthcare workers, pregnant women, lactating women, and healthcare workers with comorbidities to try and understand the immune response that we see in South Africa and make sure it's comparable to all parts of the world. We're also very interested in coagulation and coagulopathy. We want to make sure we don't see anything that's untoward, and so we'll also be evaluating coagulation factors when we do the jab to give us a bit more information on thromboembolic events. So I'm going to just end now. Linda Gelbeck is also on. I don't know if she wants to say a few words. We're very happy that most of the breakthrough infections have been mild, and we do see an impact of this vaccine on reducing the risk of severe infection. Linda Gelbeck, I'm not too sure if you want to say anything.
I think that's great, Linda. Thanks so much.
Thanks, Professor Gray. Please don't go away yet. Professor Gray, there's a lot of medical jargon that we might understand amongst us, but I guess what people just want to know is, during the third wave, are our healthcare workers who are still working in the front line, who have been vaccinated, protected?
So we see a good immune response, which is durable. So that's an important thing. We can see good T-cell immunity and good binding and neutralizing antibodies. And we see that even if there are breakthrough infections, this vaccine has reduced your risk of severe or critical disease. And so our healthcare workers will have a reduced risk of getting severe disease. We still believe that healthcare workers must use their PPE, they must use masks, they must wash their hands, they must adhere to social distancing. A lot of infections that healthcare worker gets are community acquired. And we have to make sure that while they're at the place of work, they have optimal PPE, and when they are at home, they protect themselves from community acquisition of SARS-CoV-2. Thanks.
Thank you, Prof. Much appreciated. Thank you so much. And finally, let us invite Professor Helen Rees from SAPRA. Professor Rees, are you ready? Thank you very much. Please talk to us about all the other vaccines from the East and the West, from Cuba, and what's happening with those. Thank you so much.
No, thank you very much, and good morning, Honourable Minister, Deputy Minister, DG, my colleagues on the panel, and also the journalists who are sending questions through, and to the listeners. So before I talk about those vaccines, and I know that there are real questions that we need to explain to people, and I'll get to that, I just want to explain something about how we are selecting vaccines and what the role of SAPRA as a drug regulator is, and what the role of the vaccine MAC is at a very high level. And we have Professor Barry Shube, who chairs that committee, also on this panel. So first of all, SAPRA is the drug regulator, and the role of SAPRA is written into law. And what we have to do in the case of vaccines is ensure that vaccines are safe, that they're of good quality, which means that they're manufactured properly, and by the time they arrive in this country, if they come from other countries, that they are still of a very good standard, and that they're effective. The way that we look at effectiveness and safety in the first instance for a vaccine is to look at the clinical trial data that's presented to us. So the drug regulator doesn't itself do clinical trials. We depend on academics, on researchers. We just heard Professor Glenda Gray, and the pharmaceutical industry who are developing some of these vaccines. We depend on them to generate the data, which they then put into a dossier and they present to us. And they present a lot of information from everything about what's happened in the laboratory, in clinical assessment, in the manufacturing process, and how they intend to monitor the safety once the vaccine is introduced, that the applicant applies for. The second thing is that SAPRA itself doesn't go out and look for vaccines. That's not the role of the regulator. But local applicants approach the regulator with an application, in this case for a COVID vaccine. And from the outset, SAPRA has prioritized the evaluation of COVID vaccines. We have the CEO who's really led the charge on this, but she's supported by committees of experts, academics, experts in vaccines, and also a staff who have been really dedicated to looking at all aspects of COVID and fast tracking it through the system. So every vaccine application that's been received has been fast tracked. So the question then is, where are we with the applications? So far, the vaccines that have been approved by SAHPRA for emergency use is AstraZeneca, Pfizer, and J&J. The vaccines that we have in the pipeline are the Sputnik vaccine and the Sinovac vaccine. Other vaccines that people have been asking about are not under review because we don't have an application for them. And so that's things like Novavax, Sinopharm, the Cuban vaccine that we've been hearing a lot about. We don't have applications for those vaccines at the moment, so they're not under review. So let me talk about where we are with Sputnik and Sinovac, because those are the two that many people are saying, why does it seem to be taking so long that they are being under review? Well, it's actually not taking a long time. For the Sputnik, the applicant, there are two applicants, and what they are doing is what's called a rolling review. So as they get data, they're submitting it to the regulator, and the regulator is reviewing that data on a continuous basis, and that speeds things up. That doesn't mean that you suddenly get a huge file of information that suddenly the regulator has to try and evaluate from all of those different perspectives. So that really speeds the process up. They are still submitting some of that data, so we don't have all the data that's required for a complete review yet. So that's Sputnik. Sinovac, similarly, when they first applied, we needed more data. And so there's been ongoing dialogue with the Sinovac applicants, as with the Sputnik, in fact, as with all the applicants for these vaccines. It's not just a file that gets put on a desk. The regulatory authority talks backwards and forwards and says, we need this, have you got that? Can you tell us more about this? It's an iterative backwards and forwards discussion that occurs with applicants. Now, the Sinovac applicants have now submitted to the regulator the same information as they have submitted to the World Health Organization. And many of you will have heard that the World Health Organization in the last couple of weeks gave what's called an emergency use listing for Sinovac. So we work as SAHPRA with the World Health Organization. We've been in continuous contact with them. And in the last 48 hours, we have received their dossier of evaluation of the Sinovac vaccine. It's still under embargo, but it has allowed the regulatory authorities, so the CEO and her team, together with these experts, are now looking closely at the WHO's evaluation of Sinovac. So that's going to help us speed up what we're looking at. But I want to say something very important about, and it really builds on what Professor Glenda Gray has just said. None of these COVID vaccines are 100% effective. Some in the early studies appear to be more effective than others, but none are 100% effective. The second thing is that none of these vaccines were initially developed to be effective against the variant, what we call the beta variant that we have circulating in South Africa. They were all developed against the original virus that came from Wuhan. And what we are seeing with all the vaccines, to a greater or a lesser extent, that their effectiveness is altered by the variant that's circulating in South Africa. What that means is they all appear to be somewhat less effective, but they do all appear to have activity against severe disease and hospitalization, which is very good news. But not all vaccines are equal in this regard. And so we have to look at every vaccine independently and say, what is the information we have here? What do we think about the effectiveness of this vaccine in the context of the epidemic that we have in South Africa? Do we think it's going to work against our variant? So that comes to the next very important thing that the regulator does and is doing with the Department of Health and with specialized committees. And that is that after we introduce a vaccine, especially as all of these are new vaccines, that we monitor what is happening in the general population with respect to this vaccine. In particular, we monitor looking for any safety signals that might not have been seen in the original clinical trials. So we monitor for safety signals. Is there anything that worries us? Not only in South Africa, but we're also looking around and working with the World Health Organization and other regulatory authorities, looking at safety signals that might be emerging worldwide, and then saying, is this something that could have been caused by a vaccine? How common is it? Is it very rare? And then how do we respond to it? But we also, because of our variant and because we don't know how well some of these vaccines are going to perform in the context of our particular virus, we are also looking at what we call effectiveness. So we're working with the MRC, with senior academics in the country to develop a national protocol that's going to monitor every vaccine that we roll out to say, how well is this vaccine working? Is it protecting? Are we seeing a lot of breakthrough infections? If we see infections, are they severe illness, or actually are we seeing that even if there are infections, that we're reducing severe illness and death? And so we're looking now at how we are going to measure the effectiveness of those vaccines in that in our context. So all of that's happening. So the regulator doesn't stop with just an approval. The regulator will be continuing to monitor effectiveness. And lastly, there's another group that's very important, the Vaccine Ministerial Advisory Committee, and they have a slightly different role. While the regulator looks at safety, quality, and efficacy and is governed by legislation, the Ministerial Advisory Committee will also look at safety and efficacy. How well does the vaccine work? How well will it work in our setting against our variant? But they also look at things like how appropriate is vaccine A or B in terms of the program. Does it need 1 dose? Does it need 2 doses? Does it need very, very cold temperatures? Is that going to be a challenge? And also, what is the price of the vaccine? And that dialogue, obviously, it takes place with a recommendation with the Department of Health and with Treasury. So this is where we are at the moment. And what I would say to everyone is watch that space. The requirements when we register any vaccine might well differ from vaccine to vaccine, but this is where we've got to at the moment. Thank you so much.
Thank you so much, Professor Rees, for bringing us into your confidence. I think it's really important to understand the work that gets done by SAHPRA. We're ready to move on to our questions answer session. But while we prepare for that, I just wanted to say that Professor Rees, I was listening to you at a webinar not so long ago, saying that, it's, when you go to a pharmacy or if you go to a hospital and you get a drip or if you get an over-the-counter medication, you don't worry about whether it's going to work or not. You don't worry about how safe it is. And that's because of the work of SAHPRA. And we've never really dived into SAHPRA as a public. And this pandemic has actually really brought us into the inner workings of SAHPRA. And so really we must appreciate that, the work that is done by SAHPRA gives us all peace of mind as we go out there and, we heal ourselves or in the case of us doctors, heal other people. I just wanted to make that observation because I thought it was a very interesting thing that you said at that press briefing. Thank you, Professor Rees. We're going to go on to the question and answer session, and with the Minister's permission, I'm going to start with the questions that have come from our media colleagues. And I think I will take 5 at a time, Minister. And of course, the Minister does have a panel of officials, experts, etc. You can call on anybody that you'd like to maybe assist with those questions. But let me start with about 5, and then we'll take it from there. So we have a question from, my apologies. So let's start. We have a question from Angelo Coppola from CGTN. And the question for the Minister is, please provide more details on why Charlotte Maxeke is still closed over 2 months since the fire, and when will it be reopened? We have a question from Alex Winning, and actually this is a frequently asked question, colleagues. Everybody wants to know what happens after June. They've all seen with Pfizer, they've all seen the schedule for June, but then what happens in July? Can we maybe crystallize that schedule? His second question then is, how many South African healthcare workers have been vaccinated in total, taking into account both the Sosonke protocol and immunization since phase 2 began? If we have that data disaggregated, that would be great. And then I think the third question comes from Sophie Mugwena at SABC. The Solidarity Fund and Treasury paid for procurement of vaccines through the COVAX facility. When is South Africa going to receive its first consignment from COVAX? And question 2, how long does it take for the regulator to process requests for vaccine emergency approval? I think Professor Rees has covered you, Sophie. I hope that she has. And then let's take maybe 2 more. Nathan Giffen from Groundup is adding to, okay, yes, that frequently asked question on the Pfizer. And are we counting 6 doses per vial? He just wants to confirm. Because some healthcare workers are saying it's tricky to actually get that 6th dose out. And then the last one is Vendel from Reuters. Yesterday, Minister told lawmakers that there are 64 health workers who tested positive in the last 7 days. Are any of these latest infections amongst health workers who have already received vaccines, or are they amongst those who did not receive vaccination? So I think Vendel, Professor Glenda Gray has covered us there. She has spoken about breakthrough infections, that there were a handful, that there were healthcare workers, a handful of them were severe disease, and there was also a couple who had clots, although most of the breakthrough infections were minor. Then for Professor Rees, this was a minister, they did specifically ask Professor Rees to answer this question: is there any political pressure from government bring boards to bear and regulator to push through vaccines faster? And I think that she has covered us by saying that we are taking rolling submissions. So that's really how we're trying to fast track the process. And then the next question is, in the pipeline of potential vaccine candidates seeking regulatory approval, where would you place the Sputnik vaccine? Is it fair to say that because of uncertainty, especially regarding the 2nd dose, potential impact on HIV infections in SA, the Sputnik is sort of last on the list because so much outstanding data? Is it fair to say at this stage that it is unlikely that Sputnik will be used in SA given these data gaps? So I think, Professor Rees, maybe you can come back and talk about that Ad5 component and the issues that it poses in terms of HIV. But let me start with the Minister. And let's take it from there. Thank you, Minister.
Thank you very much, Lwazi, and thanks for the questions. I think let me start with the issue. I'll talk to the issue of Charlotte Maxeke. As I said, that Charlotte Maxeke remains critical for us in terms of the work schedule, in terms of resolving the matter. We have received an update to say that because they've broken down the work in terms of phases, we can now confirm by next week the oncology side at Charlotte Maxeke will be handed over to start operating, which is phase 1. And then once the phase 2, we have a date, we'll announce together with the province. But I can confirm that work has been done. It was based on what needed to do. I think the other issue which has been a challenge is around the dose that needs to be manufactured, the fire dose that needed to be manufactured. And that took longer to be able to get. Without those, the certificates would not have been issued. So now we're getting that has been sorted, they're being installed, and next week there will be, and the oncology part will be handed over. So we are not going to relax. We'll continue to talk to the province to assist us in terms of making sure that we can be able to respond and get Charlotte Maxeke back on track. We understand its importance in terms of its operation within the province. Lwazi, we do have the Deputy Minister as well here, and I think in the panel of responding, if we could be able to allow him also to come in to assist in the responding of the questions around. That was what was directed to me, Lwazi, as I picked up. And then I've responded to the issue of the intervention to Sokutu in the chat group. I don't know if you want me to say it directly here while I'm here. In terms of the province, we've not received the request for intervening in terms of the military for compliance regulation that will be in the security cluster. The request that we received was the health practitioners to assist with the capacity, and that has been responded to. Should the need arise for that, it will be done through the security cluster, not through us as well. Thanks.
Thank you, Minister. Deputy Minister, Dr. Joe Phaahla, I did see that the Deputy Minister is here. I just want to check with the Deputy Minister if there's any of the questions that the Deputy Minister would like to pick up.
Not now, Lwazi, you can pass, I'll come in later.
All right. Thank you very much, DM, thank you. Right, let's see. I think if I can maybe ask Dr. Anban Pillay to maybe just talk a little bit about the pipeline of Pfizer, and maybe you can also pick up the question on COVAX, Dr. Pillay.
Thank you, Dr. Manzi. I think I'm having some difficulty putting my video on, but
all right, I'll keep mine
I hope
on.
you can hear me.
Okay.
Okay. Yeah, I think in terms of the pipeline, you will recall that the manufacturers had indicated to us that in the first quarter, that is of the year, meaning from January through to March, and then from April through to June, their supplies will be fairly limited. And you would have noted that over this period, we've had very low delivery of vaccine. However, from Q3, which starts basically in July, the quantities of vaccine that are going to be coming through are fairly significant, both from Pfizer as well as Johnson & Johnson. And although there was the challenge relating to Johnson & Johnson around their supply in Q2, I think they have addressed that now, and we can probably see quite significant doses of the J&J coming through in Q3. Pfizer as well as I can also say that
Dr. Pillay, I think
COVAX
we've lost
deliveries will be coming through towards the end of this month. So we will see a lot more vaccine being available in Q3. And I think you then see our vaccination numbers increase significantly since our
Thank you. I think we lost Dr. Pillay. Dr. Pillay, maybe if we can just try and improve the connection, we might bring you back. We heard you saying that COVAX is going to come at the end of the month, but we lost some of what you said before that. But we will bring you back a little bit later. I see the journalists are asking that you repeat your answer because we did not hear you well. But let's, in the meantime, see if we can bring Professor Helen Rees back and ask Prof, if you can just deal with that Act 5 component of Sputnik, and then also Vendor still wants to know if you are getting any political pressure as SAPRA in terms of speeding up your ratification processes. Thank you.
Thank you. Both very good and appropriate questions. So I'm going to take the second one first. Lwazi, as you said, regulatory authorities have a very particular mandate, and it's often behind the scenes. And if you're working well as a regulator, as you said, you are reassuring the population that the medicines they get, wherever they get them from, are of good quality, they work for what they say they will work for, and that they are safe. From the point of view of political pressure, the reason that regulators, including SAPRA worldwide, are governed by independent legislation is because it's very important that they're independent. We can all recognize that departments of health, politicians, community advocates, many people will have very strong views on what they believe is going to be a good medicine, a good outcome, the interpretation of clinical trial data, very strong views. And what you want is a regulator who stands to one side and independently says, does this drug work? Is it safe? Is it well manufactured? And can we monitor what happens when we roll this out? And does it independently? So what I can say is that in terms of political pressure, the pressure has been the country's pressure. It's to say as with everyone else, the regulator couldn't do business as usual in the context of COVID. Everything that, we haven't talked about many of the other things that the regulator has had to have oversight for, has required urgent attention, creative thinking within the legislation, and everything has had to be fast-tracked. And that is true of the vaccines. And that is an expectation that the Honourable Minister would have, and that Parliament would have, and the Cabinet would have. In terms of reporting, we have reported to the Parliamentary Health Portfolio Committee and the Interministerial Committee on Vaccines. But what we have reported is the kind of thing that I've just reported on here, which is where are we in the pipeline, explain why some things seem to be taking so long, and so on. But at no stage have we had political pressure around vaccine A or B or C or D. I can say that with absolute certainty. In terms of your next question, it's a very good and a somewhat technical question. So the Sputnik vaccine is what we call a viral vectored vaccine. It's an adenovirus. And what that does is that virus has been carefully manipulated to carry a little bit of genetic material into the body. And that combination tricks the body and the body's immune system into recognizing the COVID-19 virus. And that's how that vaccine works. Now, the Sputnik has got two adenovirus components. One we call Ad5 and the other we call Ad26. They're doing work on combining the two. That's what they've mostly done around the world. They also have another way of using their vaccines, which is called Sputnik Light. Have their adenovirus 26, their Ad26 vaccine. But let me just talk about the challenge with the Ad5. And we have discussed this with the Sputnik applicants. And worldwide, there is a discussion, including the World Health Organization. Some time ago, and there was an HIV vaccine trial that was undertaken in South Africa called Pambile, and also in the United States called the STEP study. And this was an adenovirus, an Ad5 vaccine, but to prevent HIV. And what was seen in those studies, both sites were stopped early because there was a suggestion that the vaccine with this Ad5 vector might have increased the risk of HIV amongst men who were uncircumcised and who had antibodies already to adenovirus 5 that they got from the community. It's quite technical. Now, we don't know what to make of that in terms of the new generation of Ad5 vaccines for COVID. We don't know whether this is going to be a concern or not a concern. These are not the same vaccines. The way that that vector has been made, that Ad5 has been made, differs between a number of these Ad5 vaccines. So what we have done is we are working with the World Health Organization, who have an expert committee that is looking at this so that we can have some thinking about it. We've spoken to the Sputnik manufacturers, and so has the World Health Organization. And this is really having ongoing thinking, and a specialist committee on looking at all the vaccines with HIV has been set up by the Vaccine MAC and has also been looked at by SAPRA. So it is something that's definitely under review, but it's not nearly as easy as saying we saw that in that study, therefore we will see that in this study with a different sort of construct of that particular vaccine. Bit complex, I'm sorry, but that's what's happening. But that's what regulators do. They pick up on anything that might be a safety issue, and they ask those questions, and they talk with the applicants. That's what we have to do.
Thank you so much, Prof. Dr. Pillay, my apologies. I don't know if we can get you back, and also if you can just be brief. We do have another 5 questions. Then I'm going to close those out. The questions in the Q&A, we will not be able to get to all of them, but I hope perhaps the panelists could perhaps assist, and the Minister and the Deputy Minister are welcome to also pick up any of those when they close out. Dr. Pillay, are you able to come back to us and just summarize what you said in the end there? Okay, I think we've lost Dr. Pillay. So what I will do then, colleagues, the media.
And thanks,
okay.
Dr. Vanzi. Apologies.
No, Dr. Pillay, I'm afraid that your connection is not great. I think what we'll do is that we will manage these with written answers, Dr. Pillay, and we'll also see how else we can maybe publicize your answer as well. I think we must move on. We are running out of time, and we don't want to upset our broadcasters. We have another 5 questions, which I really would love to address, Minister, with your permission, and then we'll close out. So is that okay, Minister? Thank you. So then I have questions from Dan Hawker at Newsroom Africa. Can you provide some clarity on the request for SANDF members to be deployed in Gauteng, and when are you expecting them to be deployed in which areas? And any details on how many are likely to be deployed and the duration? And her second question is, the department mentioned that 145 workplace sites have been identified. What is the definitive start date for the workplace vaccination? And Minister is welcome to ask Dr. Breakfast to maybe go into that. Then in the next 2 weeks, there are over 3.8 million vaccines expected to arrive. What is the rollout plan for these vaccines? Are they mainly intended for elderly South Africans, and will we see some of these going to the workplace sites? If so, please clarify the split. So that was Diane Hawker. Then I've got Heidi Jokos at ENCA. Why has the field hospital in Gauteng not been opened again, given the numbers the province is experiencing? You speak of military health helping, but can the minister please indicate how many beds will be made available, especially in Gauteng? Her second question, should there not be further restrictions given the COVID numbers experienced, especially in Gauteng? Her third question, Gauteng province has opened up to walk-ins for 60 plus at all public vaccination sites. Visiting a few, they seem empty, not as busy as before. Will other provinces also open up to walk-ins? And are you worried you won't reach the 5 million mark to vaccinate the 60 plus? Her fourth question, there are reports of a new variant emerging in Mauritius. Does health know about this, and will there be restrictions? I think maybe she meant as in travel restrictions for Mauritius. And then number 5, can we have a breakdown of vaccines coming in, J&J, and how many more Pfizer vaccines will we be getting? I think Dr. Pillay was trying to do that. So if you will allow me, Heidi, let me send you a written answer on that one. And then Dan Hooker came back and said for Dr. Glenda Gray, of the healthcare workers who did show severe illness after getting the J&J jab, do they know how it is that this happened? Is it only a handful? Sorry, it's only a handful, but it is worrisome that they show severe illness nonetheless. And considering that South Africa had to destroy 2 million J&J vaccines produced locally, what are the current goals for vaccinations in SA by the end of 2021? I guess that will be for us in the department. And then I've got 2 more, we're almost there, 2 more colleagues. Good morning, which variants, SA, India, and UK are mostly responsible for the 3rd wave, and what proportion in percentage terms do each account for? Is SA strain still the main driver of the cases? I think the short answer is yes, but we'll allow somebody to answer that. And then lastly from Muhammad Wadi from Muslim Stats SA, international passengers arriving at OR Tambo International Airport, he says, are not being screened or asked to show their PC results or even required to complete the health questionnaire. We have noted visitors from India, Pakistan, Saudi Arabia arriving without any of these documents being asked for. Why is it that these conditions are not being strictly adhered to? So I was hoping perhaps Ms. Annelies Otsele could be here, but we'll see. Thanks, Minister. Those are the last questions. Thank you.
Let's request the colleagues to answer, and then I'll wrap up after everyone else.
Razi, do you want me to answer the question?
Go ahead.
Thanks. That was a very important question. So we know, as Professor Rees has said, the B135 or beta variant that we have in South Africa has reduced the efficacy of all the vaccines. And so we do expect to see breakthrough infections. So overall, there will be people that will have severe infections, and there have been a handful of healthcare workers, and a lot of these have had lots of comorbidities as well. They've been have severe comorbidities. Every breakthrough infection we evaluate, and we try and understand, the timing of the vaccination to the immune response to see whether what was the cause of the breakthrough infection. But as we try and look at all vaccines, we do know that we do have a reduced vaccine effectiveness because of our variants. So we do expect to see breakthrough infections, and we do hope that all our breakthrough infections will be mild to moderate and not severe. And of the severe ones, there's usually a lot of comorbidities that's associated with a severe infection. And so we will continue to evaluate that and make sure that that we understand the breakthrough virus and where it's been circulating from. So thank you for that question.
Thank you so much. Prof, I'm going to put you on the spot here. Would you be able to tackle the question on the variant in Mauritius?
Yes, so I think that there is investigations ongoing, and that's also the issue about choosing the right vaccine for the right variant. And Seychelles and Mauritius have been entities that have vaccinated their populations to quite a high level and are still seeing breakthrough infections. And this could be because the variant, particularly the beta variant, which is the major circulating variant in Africa, has reduced efficacy against, so what you're probably seeing is breakthrough infections because of the variant that's circulating. And most of the variant that's circulating in Africa is the B135 or the beta variant. And that will impact on the ability of the vaccine to its effectiveness.
Thank you very much, Professor Gray. And actually, that is a very important point that you've made about the breakthrough surge in Seychelles and Mauritius. And this is why it's so important for us to actually really tailor our vaccination towards the variants. I think DG, if the DG is on, if DG can maybe tackle the question on Gauteng and the field hospitals, restrictions, or perhaps maybe the minister would have wanted to pick that up, but I'm just going to invite the DG in the meantime. And then also perhaps on the allegations of what's happening at the border. I don't know if the DG is able. DG, Dr. Buthelezi. Okay, that's okay. I think we will. I think he will just maybe minister can take that one later. Then I think there was
the DG is here, Lwazi.
Ah, there we go. Thank you, DG.
Thank you very much, Dr. Manzi. Good morning, Minister, Deputy Minister, and colleagues. I think on the Gauteng issue, we had a meeting about the field hospital, and one of the issues that we really picked up there was that the Nasrec hospital was not fully utilized. So actually then what needed to happen is that the province, when the numbers were very low, it became very expensive to maintain the field hospital that is being underutilized. So that was the main issue. However, we want to assure the public that what has been done in Gauteng, they've been able to repurpose a number of beds. So in terms of the report that we received this morning, they've been able to increase their beds by about 1,100 to ensure that they are close to 4,000, to ensure that they don't run out of beds. So that's basically what Gauteng has done. They've repurposed beds in Brokenspruit, in Chris Hani Baragwanath Hospital, and in other hospitals around the province. And they've also worked with some of the former mining hospitals to get additional beds to reach that more than 1,000 additional beds in addition to the 3,000 existing beds in the province. Well, the issue of the borders, we will need to investigate. I'm trying to get hold of our Port Health team to find out what's happening. But my understanding is that we've got very stringent screening procedures in place at OR Tambo and the other ports of entry, because as we know that the virus was initially imported into the country. So we are managing the borders very closely in terms of the protocols, in the directions, and in the regulations that we put up. I'll probably stop there for now, Dr. Manzi. Thank you very much.
Thanks, DG. Well, I've got the DG. Would you mind tackling that question on which variant is predominating? I think people are worried that this wave is being driven by other variants. But if we can just, not reassure, but just clarify that which variants currently still predominates in this particular wave.
Yeah, no. The main variant, according to our information that we have from our genomic sequencing team, is still the beta variant, which was first discovered here in South Africa. It's still the main dominant variant in the country. But I must mention that the Alpha and the Delta variants are still there, the Alpha being the original one and the Delta, the one that was initially discovered in India. They are there, but they've been maintained. So the Beta variant is still the major one that is still the driving force behind the infection in South Africa. But also in terms of what I want also to assure the South Africans is that we have a very active surveillance through the genomic sequencing team that is actually looking at most of the positive specimen to ensure that we don't have another variant circulating that we are not aware of. So that work is ongoing to ensure that we are able to pick up if there's any new variant that is probably driving the infection. But for now, we've not discovered any through our genomic sequencing team. Then let me quickly come to the issue of the vaccines. I know Dr. Pillay was trying to respond to that one. Yes, in the third quarter, we are going to have quite a good supply of the vaccines. We are expecting this coming weekend to receive more than 1,200 Pfizer vaccines. And then also before the end of the month, the Pfizer vaccines, those would be from our bilateral agreement that we have with Pfizer. But also before the end of the month, we're expecting to receive just more than 1.3 million Pfizer vaccines through the COVAX facility. That's a question that was asked. So that one is signed and sealed. We will be getting it. So we will be expecting 1.2 plus 1.3 of the Pfizer vaccines. That's quite a sizable amount of the vaccines. But then in addition, as mentioned by Dr. Crisp and by the minister, the 300,000 is in the country, and we're expecting another 1.2 million Johnson & Johnson in the next 10 days. So that would be able to also give us a bit of comfort. Pfizer, we've written to them to give us another pipeline so that from July we are very clear on what is going to be supplied in a particular time. So we are actually waiting for that, and we'll be communicating that once we've got something in black and white in terms of how the supply is going to come. So we think in the third quarter we'll be comfortable, and our numbers are going to actually not even double, and we'll be able to do more than 3 times what we are doing. Thank you very much, Dr. Manzi.
Thank you so much. Then I think let's move to close. So I think let's start with the Deputy Minister closing out. Deputy Minister, and then we will invite the Minister to come back and give us final remarks and close out for us. I know that there were some specifics requested by Diane. I think, Diane, we covered you in terms of the 3.8, where we're going to be prioritizing, etc. And at the workplace sites, Dr. Barikisna did give his presentation. Perhaps we can just engage in some of the finer details you might want to go into. But we do need to close out. And so may I please invite the Deputy Minister, Dr. Joe Pahla, to please
Thank you very much. Thank you very much, Program Director, Dr. Manzi. I know that it's been a long morning. Let me thank and pass my greetings to my colleague there, Minister Kubayi-Ngubane, and all the panelists. Thank you very much for very interactive and informative inputs and discussions. Indeed, there is no doubt that our campaign is, over the last few months, the vaccination campaign has been impacted by a number of challenges, but we are very encouraged by the fact that notwithstanding that, we have been able to be creative, to find solutions, thanks to our partners, the Medical Research Council of South Africa, led by Dr. Glenda Gray and the J&J group, for having come to the party and provided us with a stopgap measure through the Sisonke program, which has covered quite a sizable number of our health workers. We know that just through that program, we covered just under 500,000 health workers. Since then, as has been indicated, another just over 500,000 health workers have had the first dose of the Pfizer vaccine. So a lot of progress have been made. Now, we're also thankful to the support of the private sector, civil society, and leaders of community overall, churches, traditional leaders, because the vaccination program is just part of the safety of protecting our population. We still continue with all the other non-pharmaceutical measures. for which we highly depend on the cooperation of society and leadership of the society have been very key in terms of us being able to realize that. In as far as the vaccination program as has been elaborated by the various speakers from Dr. Crisp, Dr. Pillay, our Professor Rees and Glenda Gray and others, indeed, we are doing everything to make sure that we can roll out more and more vaccines, thanks to also the cooperation of our regulator, SAPRA, for being very supportive in attending to the regulatory matters. From our side, we're pulling all stops to make sure that we can get as many of the available vaccines, notwithstanding the challenges. As we know, when we thought we would have received 2 million doses of the J&J vaccine, it just came out that there were other challenges in the US where the basic ingredients are being manufactured. But we are thankful also that notwithstanding that, as already indicated by Dr. Pillay and the DG, that we have already received the 300,000 doses for teachers, and over the next week, we will be receiving further doses of the J&J vaccine. So indeed, we want to assure the members of the public that we are pulling all stops to make sure that the public can be protected. What we need is just the support, cooperation, make sure that more and more people, the over 60, as we open up to other sectors, the workplaces, that people come forward to register and be vaccinated. We are aware that it's a major challenge in terms of reaching our targets. We're still hopeful with the many doses we'll be receiving in the third quarter and fourth quarter that we should be able to still be close to our target of January 2022 to have reached 67% of the population. I also just want to remind our people that while we're doing all this to manage the COVID-19 and protect our people, we are not oblivious of the fact that we must continue to provide other services. Non-communicable diseases such as diabetes, hypertension, heart disease, mental illness, cancers, all the cancers are still there with us. So let us all continue to use our health services to make sure that we can protect ourselves. Modiro wa rena wa go thibela bolwetse bja corona o santse o tswela pele a re tsweleng pele re ingwadiseng ba re se gore ra ngwadisa gagolo ba bagolo ba mengwaga e 60 go ya godimo a re ba thuseng go ngwadisa re ye mo mafelong a meento re tswele pele go enta re kwele gape le gore batho ba belaela ka gore mafelelong a beke mafelo a rena ga a bule re boletse le badirisani ba rena ba di-province gore mafelo a bulege gore batho ba kgone go ka hwetša ditirelo tša meento le go ngwadisa le ka mafelelong a beke. Let me leave it there, Program Director. I know it's been a long morning. Thank you.
Thank you very much, Honourable Deputy Minister. And finally, let us invite back the Honourable Acting Minister to close us out. Thank you, Minister.
Thank you very much, Dr. Lwazi. Let me take this opportunity to thank all our panelists, our experts who joined us today to help us unpack what we are doing to the nation, simplify the issues and answer the questions. We'll continue these briefings to ensure that the nation is kept abreast with the issues that they've been raising with us. I think there's one thing that I need to clarify in terms of the walk-ins that has come up. One of the things that we have learned is that in the vaccine side, there are walk-ins. We do understand that we have issued a communique that says we do not encourage walk-ins, but we've picked up in some of the areas they are unavoidable. What we've taken as a decision is that we are going to develop protocols so that those that do necessarily end up doing walk-ins can understand what has to be complied with, and for the health practitioners so that they can be able to know what to do. We do not want to see our vaccine sites becoming centers of the spread of the disease. So that's why it's very important that we have to develop these protocols, but we do understand the constraint in our social environment and our country that sometimes these are unavoidable. There are lessons that we are going to learn from some of the provinces in taking a deep dive in what they've been able to do to contain and manage their walk-ins. Just in conclusion, I want to reiterate to South Africans again all political parties, all leaders in society, we urge you, we plead with you to assist us to fight the pandemic. Health practitioners, frontline staff can't do it alone. We need you all. To political party leaders, we do note that there is an issue concern some of you have been raising around the issue of the elections, that you have to do your work. We do urge you to find the necessary platform to have these conversations, but don't risk the lives of your supporters, don't risk the lives of your members. The pandemic, where we are now, we are in the third wave, the numbers continue to increase, and as we are monitoring across the country, no province can say it is safe right now. So we are urging you, as you do your work, please do so responsibly. To all leaders in our society, whether it's religious leaders, health practitioners, traditional leaders, civil society movements, we need you to help us, youth organizations as well. We need you to help us to pass the message that we are in the third wave, and therefore we need to preserve lives, and also urge people in communities to observe our non-pharmaceutical protocols by wearing their masks, by social distancing, by washing their hands and sanitizing, but also by avoiding gatherings. To those who are in the economic sector, our malls, our businesses, please ensure that your centers have necessary sanitizers. People observe social distancing and wearing their mask when they come. To our taxi industry, please, we plead with you, ensure that you adhere to the protocols. To the schools, Minister Motshekga has issued a communique that no sporting activities in schools, both private and public schools, we are urging you to stop the sporting activities. We can all fight and win this battle when we work together. We continue to appeal to you. Those restrictions apply. Those who are selling alcohol, please observe what has been issued in terms of the regulations. This you will be doing by preserving this economy, by preserving this country, by preserving lives and livelihoods. We thank you, South Africans, for continuing to work with us and supporting us, to the health practitioners and all frontline staff. We appreciate you. We thank you for the dedication and support. We thank you for the sacrifices that you're making for this country, and we recognize you. Thank you very much, Lwazi, and thank you very much to the broadcasters who are our partners, all media houses. We thank you for continuing to carry the message as we pass through to South Africans.
Thank you, Minister. There's nothing further to be said. We close this press briefing.